Hi, I'm Kian Fan.
And I'm Shirley Quach.
I'm Jennifer Nguyen, and we're doing our project on hospital readmission. So the hospital readmission policy is part of the Affordable Care Act. We're going to talk a little bit about the background. Readmission is costly to patients, insurance companies, and taxpayers. Nearly 1 in 5 Medicare patients are discharged from the hospital and they become readmitted within 30 days. Because of this, has caused the healthcare $17.4 billion, and that can be saved annually by preventing readmission. On top of that, when a patient comes back with an unplanned return, it can further limit hospital resources. It limits the opportunity to treat another patient who possibly could need greater care, and also negatively impacts the patient's quality of life. So reducing the number of 30-day readmission is important not only for institutions, but also for patients. And then on top of that, it's also a sign of low quality care. So this hospital readmission policy is listed in the Affordable Care Act under Section 3025. It became effective October 1st of 2012. What it includes is it defines readmission, which is basically anyone who gets readmitted 30 days after being discharged from the same or a different hospital. Some conditions that are applicable for this policy includes myocardial infarction, heart failure, pneumonia, COPD, total knee and hip arthroplasty, which were added in 2015. So Section 3025 also includes a method to calculate excess readmission ratio for each of the conditions I listed earlier. This is used to calculate readmission payment adjustment, and is also used to compare to the national average to measure their readmission performance. You can see the equation below of how to calculate excess readmission ratio.
So in 2007, Medicare started recording 30-day readmission rates at several of their hospitals. In this graph, which shows the 30-day all-condition Medicare readmission rates, the y-axis we have the percentage of 30-day readmission, and then on the x-axis we have the years from 2007 to 2013. As we can see from 2007, there is a decrease in 30-day readmission rates to 2013. In February 2013, CMS reported to Congress that the all-cause Medicare readmission rate had dropped from 19% to 17.8% in the last quarter of 2012. And in June 2013, the Medicare Payment Advisory Commission, MedPAC, reported that the reduction in readmission rates for pneumonia, MI, congestive heart failure was greater than the rate for all causes. The CMS Office of the Actuary projects that once this provision is fully implemented, it will reduce Medicare costs by $8.2 billion from implementation through 2019. This could potentially improve transitions of beneficiaries from the inpatient hospital setting to other care settings. It can also improve care and patient experience by opening up collaborative opportunities between hospital leaders and care coordination programs.
Now we'll be discussing a few limitations of the hospital readmissions provision. So let's jump to the last bullet point there. The provision does not exclude readmissions for unrelated conditions. So for example, a patient who is discharged with an acute myocardial infarction readmitted 2 weeks later for a motor vehicle accident would count against the hospital as a readmission. Also, demographic variables such as race, ethnicity, preferred language, and socioeconomic variables such as education level and income are not included in the Affordable Care Act. Hospitals that treat the poor are hit the hardest. The poor population are more likely to get readmitted because they'll have a tougher time affording medications, lack access to doctors, and they'll have difficulty securing transportation for follow-ups. In Kaiser's analysis, 76% of hospitals that have a larger number of low-income patients will be penalized versus 55% of hospitals that treat fewer low-income patients. Dr. Ross conducted a systematic review of 117 studies that included models to assess relationship between patient characteristics and heart failure readmission rates. Several studies were identified in which race, ethnicity, living status, insurance, and income were significantly associated with heart failure readmissions. In 2006, Dr. Rathore conducted a retrospective analysis of Medicare records to evaluate relationship among social economic status, quality of inpatient care, and outcomes specifically for heart failure. They concluded that socioeconomic status was independently and significantly associated with higher one-year readmission and mortality rates. The Agency for Healthcare Research and Quality evaluated the national frequency and costs of preventable hospitalizations. They concluded that the rates of hospitalization for all 12 adult medical conditions were higher in patients residing in the lowest income communities compared to those living in the highest income communities. In 2009, Robert Wood Johnson Foundation assessed education levels and its effect on health. They concluded that compared with the most educated adults, the least educated adults in every state were more likely to be in less than very good health.
So thanks for listening to our podcast. After this is done, you should be able to define and identify what the hospital readmission provision is and also some benefits and limitations. Have a good day.